So we're sort of getting into splint design now. Let's look at what is causing that activity. And it's this parafunction and these occluding schemes that occur that allows these signs and symptoms to happen. Here's primary clenching. That person wouldn't have any wear facets, perhaps. They may not complain to you about any facial pain or joint pain. They might wake up with a headache all the time and never tell you about it. Here's contralateral joint strain. We call this the working side, as if someone's chewing food right now. It just means the condyles translate on the opposite side, so we call it the working side over here, as if that's where you would be chewing food, because this side is translated. This is during a closure event, but we still use that term working as if it's a normal thing. If the contact on the same mandible, they're all in the same excursive position, but the contact has just changed its position. Here's a posterior contact below the translated condyle. That's a great way to crush a disc. Canine resistance, which we love, we use the canine as the patient is opening and the canines are rising up on each other. That's great. Opening, I love an opening movement. It's when they start to reverse field, go the other way. Sometimes they'll go all the way up and they'll go canine to canine and they'll squeeze like crazy. There's a new occluding resistance. Sometimes you have canine resistance. The canine tips are flat. Or protrusive resistance. I call these protrusive clenchers. Sometimes they'll go right past the inside, they'll flip-flop. So you treat them with a splint. Here's a lower flat plane splint with canine rise. If you were to provide that splint, they could still clench like crazy. You probably wouldn't make that for a primary clencher with a complaint of headache and nothing else. You probably wouldn't even know they were a patient to be treated. But in excursive movement here, so we got a little canine rise, and now we instant posterior discluding. Now we don't have joint strain. Pretty good splint for someone who has a joint problem, because the joint strain and problem comes from the occluding schemes that we've just eliminated. Because back when they were centrically clenching, we had posterior support for the joint, or constriction or resistance. We didn't let it move. We still have canine through canine clenching on one side, 70% of maximum, so you could still have a headache patient. That might not change them at all. If you go back to center and slide forward, here we have incisal edge contact on that splint, and so you eliminate this protrusive resistance. So we still have some things that are still left over and why this splint didn't help that particular presentation. It's back to this canine problem right there. Pete Dawson said in his textbook a while back, after occlusal treatment of any kind, I ask the patient to close and clench as hard as they can. Okay, he's got that out of the way. Can you clench? Does it hurt? No. I ask them to grit their teeth and grind in all directions. Why? He wants to know if there's going to be a posterior contact in an excursive movement, because if they can elicit any sign of discomfort, I know I'm not finished, because when I have complete harmony with CR means there are no interferences going into and out of CR posteriorly. That's what he means by harmony. It's impossible for the patient to feel discomfort in the joint. That's where dentistry lives. We're trying to make, look, you got no joint pain. Ta-da! Clench on your splint, clench on your occlusion, grind to the side. Are there posterior contacts? Because if there's not a way to strain your joint. So that's what he's looking for. Interestingly, now in his latest textbook, he talks about the NTI. What we did not realize in past splint fabrication is that canine contact does, in fact, permit an increase in muscle contraction activity over a single midline point stop. The difference is significant enough to warrant its use in diagnosis as well as for clenching suppression in selected patients who continue to clench even with a perfected occlusion. We're still convinced if the occlusion was just perfect, why would you clench? Because a long time ago on that slide it said a posterior interference would cause muscle hyperactivity. We think that posterior contacts were causing muscle hyperactivity. If you have a perfect splint, there's no interferences, therefore you won't clench intensely. It's not true. So the selected clench even with a perfective occlusion. So now, Dr. Dawson, you know what? Some people have perfect occlusion, they clench anyway. It might not be because of the occluding scheme.